I have been asked to introduce today's speaker, whom I know fairly well. His name is Dr. James W. Peer, PhD. I call him Seamus. His college friends call him Jimbo. Almost nobody calls him James, except me when I was mad at him.
True story.
And Jim went to Marquette University High School and then took off for the East and studied at Boston College, obtaining a psychology degree. Then he took a couple years off, looking for graduate school and working at a psychiatric hospital. He ended up getting his PhD in clinical psychology at Loyola University in Chicago, so he was survived for a little while, and then went to Yale for an internship and Hartford Hospital for a postdoc residency. Thus, the neuropsychology. And I've asked him to tell us all a little bit about what the heck that means and what he does as a neuropsychologist. Jim? Have at it. Thank you.
So I don't often begin my talks by saying thanks, Mom, but thanks, Mom. Well, I'm very happy to be here this afternoon to talk about something near and dear to my heart, and I think to all of you as well, which is the human brain. The human brain is the most complex thing in the known universe. And so to try to talk about it in an hour is an ambitious endeavor. I'm going to cover a fair amount of material, but we'll do the best we can to squeeze in a lot of information. And then I'm happy to stick around for questions and discussion, brainstorming afterward for as long as people might be interested in doing so. So we're going to talk a little bit about the human brain itself, the process of normal aging, and then some aspects of not so normal aging, including diagnoses of conditions of Alzheimer's disease and Parkinson's disease, and hopefully on an optimistic note to talk about treatment and preservation of brain function and where we go from here. As my mom mentioned, she wanted me to say a little bit about what is a psychologist. So neuropsychologists are doctoral level providers in psychology. So most of us have either a PhD, a PsyD, which is a doctor of psychology, or an EDD, a doctorate in education. And neuropsychologists are concerned with the study, evaluation, and treatment of just about anything that can be described as a human experience. We are a greedy lot. We like to think everything is under the purview of neuropsychology. And so most neuropsychologists are involved with developmental conditions like autism, attention deficit hyperactivity disorder, learning disorders, acquired conditions such as traumatic brain injury, acquired injuries through stroke, cerebrovascular accidents, a whole range of neurologic illnesses and injuries, Alzheimer's disease, Parkinson's disease, multiple sclerosis. It's a long list. But as well as psychiatric conditions, so many neuropsychologists will work with individuals impacted by schizophrenia, bipolar disorder, depression, and anxiety. And then increasingly, neuropsychologists are finding themselves involved in primary care and medical settings because in the past decade or so, we have become increasingly aware of the potential for a whole panoply of medical illnesses and conditions to impact our cognitive functioning, our behavior, our mood. So conditions such as diabetes, seizure disorders, kidney and liver problems, infectious processes, and also recognizing the potential for medications to have side effects that can interrupt or disrupt cognitive functioning. So it is a lengthy list, but it also provides for a fascinating career, and it's really a blessing to be able to interact with folks to try to help patients, their families, their healthcare providers to understand and to maximize brain function. Neuropsychologists are in different settings: hospitals, primary care settings, private practices, rehabilitation hospitals, and also I do a fair amount in the forensic world. So I travel to many of the prisons in Connecticut, for example, to evaluate inmates because the court system, the criminal justice system, is eager to know if there might be factors that the court should consider potentially for mitigation at sentencing, for example, for an individual. So their psychosocial upbringing, their biopsychosocial factors, the exposure to substance abuse, trauma as a child, all these things that can affect how the brain develops and functions. So it really is a fascinating career and a wonderful discipline. A couple of caveats I want to mention about today is that we all have glitches, and these glitches become more numerous, more frequent, and perhaps more distressing as we get a little bit older. And so just to prove that point, and I hope you all appreciate the great courtesy that I did you, I traveled here from Connecticut and left my power cord of my computer in my office in Connecticut. So last night when I was when I was going over my slides, I have an old computer, the battery is diminished quickly. I realized I needed a power cord. Thanks to Sandra Meyer, I was able to scoot up to Best Buy in her car to get one. So again, I hope you appreciate that. That was simply for purpose of illustration about these issues. So we are not going to make any diagnoses today. I'm not giving you specific medical advice. It's just an opportunity for us to talk about and think about some issues that I think are very important. I will say, though, that if in the course of this talk, or if you already have concerns, not just to stew with those. Don't just sit with it. Talk to family members, talk to your primary care provider, get some help to try to figure out what might be going on, because some things are benign, even if they're frustrating. Some things might not be benign, and happily, increasingly these days, there are treatments that are available. And so, even though it can be scary to find out what is it, knowing provides the power to try to do something about it, to cope, to manage, to treat. Okay. So again, please don't jump to conclusions. I can almost guarantee that at some point you are all going to say to yourselves, or maybe to the people next to you, "Oh my God, I do that," or "I did that this morning." So we have to recognize that that's something that we'll encounter today. Okay, and a quick dedication. I just want to mention that I dedicate this talk and a lot of what I do to my parents, to Joanne and Bill Peer, who lived about the last 15 years of my dad's life with Alzheimer's disease and found a way to do that with grace and love and even joy. And I also want to give a shout out to the Amazing Grace Chorus and to Wisconsin Alzheimer's Association, who are just magnificent people, magnificent organizations, and they will insist and have proved to me and to many people that there's still music and joy possible, even in the midst of this miserable disease, Alzheimer's disease. So dedication and a hearty thanks to all of those folks. Okay, so our amazing brain. Everything we do, think, feel, experience, perceive, reflects some aspect of brain function. That sounds like such a basic thing to say, but it's important to keep sight of that, because if there is injury or illness that affects the brain, it can impact everything and anything that we do. Our vision, our thoughts, our memory, but also our emotions, even our personality style. And sometimes people are surprised by that when a loved one or a neighbor or a parent or a child encounters an illness or an injury that impacts brain function, to find that there can be really changes that affect the intimate details of who that person is. But unfortunately, it can. So it's important to keep that in mind. Here's a picture of an MRI of the brain. So you see on the left side, you can see the person's nose. So this is the front of the brain here. This structure is called the corpus callosum. It's a thick bundle of fibers that connects the left side of the brain with the right side of the brain. And then you can see that this is the cortex. This is the computer part of the brain. These folds of brain tissue, and then more primitive life-sustaining structures down there. So just to give you a sense of this thing we call the brain. Here are some interesting statistics. The average brain only weighs about 3 pounds, about 1,400 grams for the average adult. So that's only 2% of the body weight for a person who weighs 150 pounds. Yet the brain receives between 20 and 25% of the blood circulated by the heart. So there's a good clue to not only the importance of the brain, but the phenomenal amount of activity that is happening in the brain. Its need for oxygen, glucose, and also to take away the metabolic waste that occurs from brain activity. And that activity reflects the amazingly integrated functioning of over 100 billion neurons. I mentioned the blood supply that the brain requires from our cardiovascular system. So here's a picture of the cerebral vascular system in the brain with the brain tissue itself subtracted away. That just gives you a sense of this vast network of blood vessels that bring blood to and take it away from the brain. Okay, as we jump in, I'm going to give you a spoiler alert. So if you're already bored, before you leave, one quick thought. Move it and use it or lose it. Very true axiom for the brain. We have to use it, but we also have to use our body because our physiological fitness, the ability of our cardiovascular system to get oxygenated blood up to the brain is incredibly important. And the good news is that any and all activity helps at any age. It is never too late to start. It's never too late to improve what we're doing in terms of physical exercise, physical activity. So if you had to say, Jim, tell me just one thing about enhancing the physiological functioning of my brain. I want to protect it. The answer is easy. It's physical exercise. Now, there are other things to do, and you might do a calculus and you might say, well, I'm doing okay, and there are other things I want, and we'll talk about a lot of other really important aspects to enhance brain function, to enhance quality of life, but physical exercise is crucially important. I'm going to come back to this a little bit later. And I saw, is it Alex? I saw Alex in the gym earlier today, pumping away, so good for you, Alex, and it's a beautiful facility down there. So, okay. Let's talk a little bit about normal aging, because the fact is that the brain changes as we get older, and these changes start at a disappointingly early age, about 35 years old. The brain starts to change. Okay? And along with that are changes in our functioning that are frustrating but generally benign. So you might say, oh, I hate when this happens, but it's not something about which you need to be alarmed. And one of the clues to normal aging is that we're able to compensate for the difficulties fairly easy by writing notes to ourselves, making a list, setting an alarm on our phone, those sorts of things. And the brain changes that underscore or underlie these cognitive changes are atrophy, so the brain literally shrinks, vascular changes, so they're especially in terms of the connecting fibers of the brain. There are very small blood vessels that go deep into the brain, and they tend to get plugged soonest because they are small. So problems like high blood pressure, high cholesterol, obesity, diabetes, cigarette smoking, those factors increase the risk for vascular changes in the brain. But to some degree, that happens for everybody. So I can almost guarantee you that if we took a detailed MRI of each of your brains, there would probably be some what's called small vessel ischemic disease. It just means small, usually benign changes in this white matter of the brain. But that kind of process starts early. And then because of that, there can be a loss of connectivity. The brain's systems and regions are amazingly adept at talking to each other, sharing information, facilitating the rapid execution of incredibly complex behaviors and thoughts and so on. And that connectivity becomes less efficient as we get older. Our thinking abilities decline in speed, and you may notice that there is an inefficiency sometimes in word retrieval. So I'll say to my wife, "Where's my whatchamacallit?" And she'll say, "It's in your who's it thinger." It's like, where's that thing? Have any of you had the experience in the past 3 days where you're talking to somebody and say, "What is that movie? I just watched it. I loved that movie. It had, you know, that guy who was in the other one?" And you're all nodding your head, so I'm going to take that in the affirmative. So these changes, though frustrating, are not cause for alarm. And our cognition becomes less efficient as well. We tend to be a little bit more forgetful, to require cues and prompts to help us retrieve information. Years ago I heard a psychiatrist speak who talked about the coffee cup game that my wife and I play all the time on Sunday morning. You pour yourself a cup of coffee, and then you get busy with stuff. And if you can find your coffee cup and drink it while it's still hot, you win the coffee cup. If you have to put it in the microwave oven, well, better luck next time. This process of normal aging is a very individual thing. There's tremendous variability among individuals, and even among the same individual, if we were to look at her or him on multiple days. Oops. And this is purposefully a very busy slide just to communicate why that might be. So there are factors that predate an injury or an illness. There are factors related. So this slide is specifically for traumatic brain injury. We could put in there diabetes, stroke, Alzheimer's disease. And then there are post-injury factors, psychosocial factors. Where do you live? With whom do you live? How much activity is there? And so there is this constant interaction among nearly countless variables that determine the extent to which an individual experiences changes in cognition, and also in the context of a disease then, the timing of onset of problems, the number and magnitude of problems, and how frequently they occur. So I just want you to keep that in mind, that there is tremendous variability. If we lined up 5 people who have all been diagnosed with Alzheimer's disease, certainly there would be some commonalities in their experiences, but they would be 5 different people with distinct cognitive profiles, strengths and weaknesses, psychological reactions to the diagnosis and to the frustrations that it brings, and so on. And in general, this variability, what we call sometimes in neuropsychology is non-specificity, is true for all different kinds of illnesses and injuries, developmental conditions that can affect the human brain and how we function. In fact, if you look at normal individuals even, you can see that symptoms and complaints are quite common. Again, even in community-dwelling, normal, healthy individuals. And so we used to say when I present this slide, whatever you do, don't let a loved one go to college, because look at university students. 19% acknowledge dizziness, 57% headaches, 82% say they can't concentrate, and 47% complain of memory complaints. Okay. But also there is tremendous overlap among neurological, developmental, psychiatric conditions. So if somebody came to me and said, "Hey Jim, I have a friend who's having some problems with memory, what do you think?" I would say, "Well, I'm sorry to hear that, but I don't know what to think beyond that. I'm sorry your friend is having memory difficulties." Because if I showed you self-report symptom inventories that are designed to identify the presence of depression, here are some of the items that you would see. True or false? My memory is worse than most people I know. I have more trouble concentrating than in the past. I have great difficulty making decisions, and I certainly have trouble focusing my thoughts. So again, these items are drawn from a scale that is designed to assess the presence of depression. Now, that doesn't mean that a depressed person couldn't also have a neurologic condition, but my point again is to keep in mind this non-specificity of symptoms that people can experience. Okay. So we talked a little bit about normal aging and some of the frustrations and difficulties people experience. Let's talk about something called mild cognitive impairment. So you can see that mild cognitive impairment, or MCI, lands between normal functioning and dementia. And there are cognitive complaints, so somebody is frustrated, concerned about their cognition, usually involving memory, but not always. But cognitive screenings are typically going to be normal. So if you go to see a primary care provider, APRN, they will do perhaps a mini mental status examination, and results of that are typically normal. And so that could be because the person is having difficulties that are not reflective of a significant brain change. In MCI, activities of daily living, dressing, grooming, bathing, taking medications, typically are preserved. And so these are not folks who meet the diagnosis, the criteria for dementia. The reason it's important not to ignore this kind of experience, though, is that many causes of MCI are potentially treatable. And so here are just a couple. So it could be prodromal Alzheimer's disease, which means the initial gradual decline that signals the emergence of Alzheimer's pathology. But it could be the result of a medical illness. So if somebody has an illness going on that interferes with their liver functioning, you can get something called an encephalopathy, where because the liver screens toxins out, if it's not working, they travel up to the brain and they cause a mental dullness and confusion. I just showed you items from a depression inventory. So these kinds of problems can be due to depression or other psychiatric illness. Oftentimes they're due to medication side effects, especially when people are taking 5 or 6 or 8 or 10 or 12 medications, many of which can have cognitive side effects. It can be due to substance abuse, if people are drinking too much or using other substances. Sleep impairment is an extraordinarily common cause of this kind of MCI. Abnormal functioning, frustrating, but not dementia. If people don't sleep well, if they're waking up in the middle of the night, if they're snoring, obstructive sleep apnea is still a woefully undiagnosed condition, especially for folks who are a little bit heavier than they should be, who snore and who don't feel rested in the morning. That's something to consider. And then there is the factor of just getting old. The single biggest risk factor for brain dysfunction and cognitive decline is getting older. That's unfortunate, but that is the case. However, again, we're going to end on a happy note, that's not the final word. There are things we can all do to try to mitigate that process and to preserve and enjoy our cognitive functioning as much as possible. Who said that? She's marry a young man, she said. It helps to be creative, right? You know, never. Okay. So I do want to shift and talk about dementia. So simply put, dementia is when there is objective cognitive impairment that now does interfere with important and basic aspects of adaptive functioning. So there's a loss of independence typically, and the effective strategies we had used previously are no longer working. Dementia is a general term. It doesn't imply a specific diagnosis or cause. Okay? So dementia just means something is going on where my cognition is sufficiently impaired that it's impacting me in my day-to-day functioning and I'm having trouble coping with it. There are many causes of dementia. Alzheimer's disease is the most common, but as I mentioned earlier, it can be due to cerebrovascular disease. So again, that process of small vessel ischemic disease, if that is undetected and if the underlying sources of that aren't treated, that can progress. Parkinson's disease, which we're going to talk about a little bit, traumatic brain injury, a Lewy body dementia, and then mixed pathologies. So there are lots of different And this is by no means an exhaustive list. When we get to a point of dementia, there are typically diagnostic studies now that will be revealing and help us understand what's going on. One of these is called a PET scan, or a positron emission tomography scan, which provides us information through pictures of the metabolic activity of the brain. And so when the brain is active, we have brighter colors. And so this is a nice, healthy 80-year-old brain, and notice all of the bright colors. Okay? Here's a PET scan of a patient with Alzheimer's disease. And so you can see the dramatic change, all the darker colors indicating hypometabolism, that is, less activity in the brain. MRIs initially in Alzheimer's disease tend to be unrevealing. It's still good to get them because it provides us a baseline. But over the course of the disease, we typically will see some changes because Alzheimer's disease hastens that atrophy, again, that shrinkage in brain that I mentioned we all experience. And so here you can see a healthy brain. These dark regions here are the lateral ventricles of the brain. They're filled with cerebrospinal fluid, which on MRI shows up as dark. And you can see the size of these this is normal, and the additional ventricles down here. Notice here how much larger the ventricles are here. That is because as the brain shrinks from abnormal pathologic atrophy, the ventricles expand to take up that space that is left as the brain atrophies. You can also notice that these spaces here that are called the sulci, the spaces between the folds of the brain, in the Alzheimer's patient, notice how much larger they are, and particularly in this region of the brain, which tends to be the memory centers of the brain particularly impacted. So we have techniques that can tell us about the pathology, the changes in the brain, but for a long time, this was helpful but frustrating because the disease was already well established by the time we got some of these types of data. Now, happily, we have biomarkers and strategies that allow us to detect some of the abnormalities associated with Alzheimer's disease much sooner. We're going to talk in a little bit about some of the treatments that are now available, and the earlier we can diagnose and treat these diseases, like most medical conditions, the better off we are. And so if we can detect the presence of Alzheimer's disease before it gets to that stage with that MRI with the large ventricles, then we're going to be better equipped to treat it. I have listed some here just so you get a sense of the blood tests, analysis of cerebrospinal fluid, and genetic testing. Basically, somewhat intrusive. A cerebrospinal fluid analysis is intrusive. They have to put a needle in the small of your back. But blood tests, genetic testing, not very invasive, and we're getting better and better at detecting downstream some of the pathologic changes that are occurring in the brain that we can detect in the blood. So a little quick overview of sort of the diagnostic process. How might this work if somebody is concerned? So there's subjective concern of the patient and family. A good place to start, if this is really a new issue, would be with primary care, because they're going to look for potentially other treatable causes of cognitive changes. Medications, other medical conditions, infections, especially things like urinary tract infections that can really affect our cognition. And then getting some imaging, MRI and PET scans of the brain, looking for these biomarkers, and then proceeding further if the concern persists to getting formal, detailed neuropsychological evaluation, which is a process that typically takes 3 to 4 hours and involves a very comprehensive assessment of reasoning, language, attention, learning, and memory, so now we have a functional snapshot of how their brain is working to link up with the biomarkers, the imaging, the clinical history, and that improves our ability to try to make precise diagnostic conclusions that will then guide treatment. Okay. So one of the things that happens in Alzheimer's disease is a conceptual confusion, loss of daily activity independence, problems with financial management, doing household tasks and driving, forgetfulness, and again, compensatory strategies would be minimally helpful. And a test that is often helpful, and many of you have probably done this when you go for your annual physical, is a clock drawing test. So here is a concerning clock. You can see that not all the numbers are in the clock and they're misplaced. This person was confused and wrote in the alphabet instead of putting the numbers in the clock. Okay. So it's a quick and easy screen. Again, many folks in primary care offices, internal medicine offices will do this. I want to mention also some of the memory problems that are typical of Alzheimer's disease. So in a very fascinating way, long-term memory and autobiographical memory are usually intact initially in the process of the disease. So patients with Alzheimer's disease can often talk about family vacations from decades ago, their favorite high school teacher. It is the new learning and recent memory that becomes problematic initially on. And there is often this process of repetition without being aware that is happening. So my dad used to do that. We would sit down at the table and we'd be talking and he would tell a story, and then 60 seconds later he would say the same story again. And if I said to him, "Dad, are you aware that you just told me the story?" there would be no awareness. So there's no aha moment when somebody says, "You forgot this," or "You already told me that." It's, "Oh, that's right. You were at the kitchen table and my sister came in and I got interrupted, but I remember that." It's different than that. It's that there's no recognition of that. So in neuropsychological evaluations, we will often use a list learning test, and then there's a delay, and then where we distract them with some other tasks. And that delay might be 10 or up to 20 minutes. And then I will say, "Now, Mr. Jones, I want you to tell me as many words from that list as you can remember." And sometimes I will get a vacant look and they will say, "What list?" So again, there's no aha. They're unfortunately been completely unable to store that list. So it's that type of memory difficulty that is kind of the signature of Alzheimer's disease. The clinical course is also important to keep in mind. So changes tend to be very gradual in Alzheimer's disease. Sudden, abrupt, dramatic changes in cognition suggest a cause other than Alzheimer's disease. However, I will tell you that sometimes patients or families will report changes in cognition and memory as if they were abrupt. They came out of the blue. But in taking a careful history, it's very often the case that, "Oh, we just moved to a new condo," or the patient's spouse passed away and we learned that the spouse was really supervising and supporting that individual, and so these supports and the familiarity of a known environment are no longer there. And so this gradual, this gradual decline looks like it came on overnight. It was simply disguised by some of these familiarities and supports. Earlier I mentioned that everything we do is mediated by brain function, and so in Alzheimer's disease there are often behavioral and personality changes as well. Sometimes these are more difficult to tolerate than the cognitive changes for family members, for loved ones, and that can include irritability and agitation, disinhibited behavior that can be embarrassing, apathy and complete lack of motivation, and sometimes a sort of obstreperous, complaining resistance to everything, from going to the bathroom before bed to taking medications and so on. These are every bit a reflection of the pathologic changes in the brain as the memory problems are. Sometimes we lose sight of that. Okay, so treatment. Alzheimer's disease, astonishingly, given how its incidence is increasing as Americans are living longer, there are more cases of it, has been the neglected stepchild of medical care for decades. Finally, this is changing. And so that is reflected in the fact that for many years there were few treatments available and no treatments available that actually affected the disease process, the pathologic changes in the brain. Happily, that has changed. So for a long time, there were basically three choices: Aricept, Exelon, and memantine. And these medications work by impacting the neurotransmitter system in the brain. Neurotransmitters are chemicals that the brain uses to talk, to build knowledge, to learn, to remember. And an important one for memory is called acetylcholine. And all these medications did, though it was important, was to make acetylcholine available to the brain for a longer period of time. There's a natural process by which the brain breaks down acetylcholine so it stops having an impact. And these medications interfered with that process, so this important substance for memory, acetylcholine, was still available. So did it help? A little bit, it did. Many patients would experience a modest boost or improvement. Some patients did not. But again, the problem was it was like putting a Band-Aid on a severed artery because it did nothing to address the underlying disease process. Okay, I'm going to mention just very quickly, there are all kinds of things that are being marketed as being brain boosters. Take this for your memory, this will help, this will prevent you from getting Alzheimer's disease, and none of them has been the subject of methodologically sound studies that are replicated by a disinterested third party. What do I mean by that? To tell you that taking Prevagen or any other substance will work, you need to really have a placebo-controlled double-blind study. That means that we have a patient group who are going to get substance X and a control group that will not get substance X, but who do get a placebo, a substance that we know won't have any impact on brain function. The patient group and the control group don't know what they're getting. The administrators of the research don't know what they're getting. So they just check off, they do their tests, and so on. And so these studies are the gold standard for making causal inferences about the impact of any type of medication. And so all of these supplements that you see in the drugstore shelves and hear about on TV, they have not been rigorously enough studied to conclude definitively that, yeah, this is helpful. It doesn't seem like any of them hurt. So if you want to try them, I'm going to dissuade you, but unfortunately, they don't seem to have any good methodologically sound empirical support for their use. But there is hope. So there are new medications, two in particular called lecanemab and donanemab. These are immunological treatments, and finally, they actually modify the disease course. What's happening in Alzheimer's disease basically is that there are abnormal proteins that in healthy functioning get excreted from the body. Okay, they get cleared from the brain. In Alzheimer's disease, that process, for reasons we don't fully understand, is diminished or it halts even. And so you get this buildup of these abnormal proteins that cause pathologic changes to the neurons, the cells in the brain that do the work, and if that process continues, we become symptomatic. These medications are helping the body to clear these harmful proteins. And so again, the key here, the paradigmatic shift is away from symptomatic management to modifying the disease pathology. It's extremely exciting. And finally, the medications are not without some side effects, which is true of any medication. You take ibuprofen, you run the risk of gastrointestinal problems, right? So anything has some side effects. These are potentially serious, involving brain bleeds and some swelling. However, most patients who have that experience, they stop the treatment, the symptoms resolve, and many of them, though not all, are able to resume treatment. I have the good fortune of collaborating with some physicians at Yale in their memory disorders clinic who are using these medications. And a week ago, I talked to one of them and I said, hey, I'm going to Wisconsin, I'm going to be giving this talk. And we had talked about some patients that we share, and I said, tell me, what's the latest? What's your thought on this? He said, yeah, we have to give them serial MRIs to monitor very carefully for this potential side effect. But he said, I'm seeing a really good outcome from these medications, and I'm seeing that when these side effects do occur, they're manageable and typically go away if we stop treatment. These drugs don't cure Alzheimer's disease. So we talk about reduction in pathology, reduction in symptoms, and that translates to improved function and quality of life. So it's wonderful, but it does not arrest or halt the disease process, unfortunately. They also have to be used early in the course of the disease. So again, the importance of getting to a physician's office, getting a diagnostic workup quickly so that the diagnosis can be made and then treatment started. There's a new medication that I just learned about, so I just thought I'd tell you about it quickly. It's a medication being developed at Northwestern University, initially as a treatment for Alzheimer's disease, for ALS, Lou Gehrig's disease, amyotrophic lateral sclerosis. And in animals trials, they are finding that if they create Alzheimer's pathology in mice and then give them this drug, it's reducing the inflammatory changes, the abnormal accretion of protein, and these degeneration of these cells in the synapse, the point at which cells are talking to each other. The hope is that if animal models continue to be promising, they could use this for prevention. So just like you might take a torvastatin, if your cholesterol level is too high, we don't say, well, your cholesterol level is too high, we're going to wait until we see coronary artery disease and then we'll give you a medication. It's like, well, no, this is a red flag, this is a potential harbinger of heart disease. Let's manage your cholesterol before it gets to that stage. So again, it's so exciting that we're finally getting to this stage where we're talking about early detection, early treatment, effective treatment, and maybe even a kind of if not inoculation, preventative measures before this terrible disease takes hold of a brain. Okay. Let me shift gears. I'm going to talk a little bit about Parkinson's disease, which is also a degenerative disease that probably has genetic and environmental factors. And this also involves the accretion of the abnormal accretion or accumulation of proteins that particularly disrupt structures in the brain called the substantia nigra. The job, one of the jobs of that structure, the substantia nigra, is to produce a substance the brain needs called dopamine, which is very intimately involved with motor movement, coordination, as well as the pleasure systems of the brain. There is a very sensitive and specific study called the DAT scan that can be done for Parkinson's disease. And the problem with, one of the many problems with Parkinson's, like Alzheimer's disease, is that by the time a diagnosis is made, the pathology has often been developing and worsening for years and even decades. In fact, I read one study that suggested that in patients with Parkinson's, it's possible that the pathologic changes, especially in substantia nigra, started as many as 40 years before the first symptom. Yeah. Like Alzheimer's disease, remember we talked about variability within a patient, between patients, and so that is certainly the case for Parkinson's disease. But some of the most common and recognizable symptoms involve motor symptoms. And that makes sense because it's a disorder that impacts the dopamine system in the brain, and because dopamine is needed for us to move, some of the initial symptoms include tremor. It usually starts on one side of the body, but as the disease progresses can affect both sides. A stiffness and slowness, loss of balance, incoordination, sometimes a freezing phenomenon, and micrographia or poor legibility. Patients with Parkinson's, if you looked at their signature over the course of a decade, it's fascinating to see it decrease in size steadily and also decrease in legibility. There are also non-motor symptoms, though, including loss of smell, which is called anosmia, constipation, problems managing saliva, something called hypophonia, where the person will speak with a very soft voice and without being aware that they're doing it. And so they may start off with normal loudness and then it almost becomes a whisper. There's often a flatness to facial affect, where patients, again, without being aware of it, will tell a funny story or something will happen and there's no change in their facial affect. You know, what we all do to express surprise or delight or anger, that ability seems to be diminished. And then sleep disturbances are very common in Parkinson's disease, especially acting out dreams. There's often thrashing about and even aggression sometimes in sleep. It's called REM disorder. REM stands for rapid eye movement. It's the stage of sleep during which we dream. There are also mood and behavior. Again, keeping this notion that everything we do can be impacted by brain disease. It's not just how we walk and talk and think and remember, but also our mood, our personality, and so on. So problems with depression, anxiety, irritability, and apathy. In patients with Parkinson's disease in particular, one of the frustrating components is this apathy or lack of motivation. And so sometimes that gets misinterpreted as being depressed. And especially early on, if there is an external inducement to do something, to go for a walk, to play bridge, to go for a swim, to visit the grandkids, whatever, that can oftentimes overcome that apathy. But for long stretches, people will just sit on a chair or on a sofa and just not do much of anything. In Parkinson's disease, some folks experience cognitive changes, some do not. Some have very minor difficulties, some have severe difficulties. Typically, if the cognitive problems are due to Parkinson's disease, they come later in the disease, after the emergence of these other symptoms, particularly the motor symptoms. That doesn't always happen, but it typically is the case. So treatment is focused on restoring this balance, addressing the dopamine system. The medications, unfortunately, have side effects. The medications often the effect of the medications sometimes wear off over time. So patients will often express frustration that they've gotten on a medication and it's really helping with their tremor, they're walking better, they're more sort of vigorous, and then after 6, 12, 18 months, it seems to flatten out the impact. And happily, though, there are options for dealing with that a neurologist can help with. But also medications for mood and behavior if that's an issue. And then particularly in Parkinson's disease, because it does impact coordination, walking, balance, physical and occupational therapy can be very helpful to deal with some of those issues, to prevent falls, which of course is critically important, but also to help with general adaptive functioning in day-to-day. There also are non-pharmacologic treatments. So there is something called deep brain stimulation, where electrodes are inserted into the brain to provide stimulation that seems to be quite effective. It's often held in sort of reserve for the possibility that medications stop being effective. And more recently, there's transcranial magnetic stimulation, or TMS, which kind of burst upon the scene as an effective non-medication treatment for depression, and they're realizing that this may be helpful as well to address some of the symptoms of Parkinson's. So I think the take-home point for Alzheimer's disease and Parkinson's treatment is this. We finally have some treatments that are effective, and the treatments are varied. They include medications, but also non-medications. We have early detection now for both of these disorders. that allows the patient to get into treatment protocols to hopefully address it, to manage the disease, to retard the progression of the disease as early as possible. Okay. And now for some hopefully good news. So there are lots of things we can do to mitigate risk, to protect our brain resources, and to optimize our quality of life. We know that many people thrive in older age, and one of the factors that has received greatest attention is social connection. But having some purpose in life through connection with family, work, volunteerism, clubs is incredibly important. And it's not just because it feels good and it is enjoyable, but we know that it's correlated with better brain structures and better brain function. This dynamic continues until we die. Being connected socially is critically important. It's very difficult to overstate the importance of that. The research on this, however, is tricky. So you can read some papers in professional journals or hear some people who are expert talk about social isolation causes dementia. I think that's overstating it, respectfully. The reason is that studies have to use a quasi-experimental design to look at this issue. We could take half of you half over there, you're going to get assigned to the experimental group. You lucky folks will play bridge and go to the theater and sing songs and go for walks. You folks, sorry. You're going to be socially isolated, no enrichment. I mean, that's what it would take to do a true experimental design that would allow us to conclude that, yes, this group suffered, and so we know that it was the social isolation. Not to mention the complexities of human functions, our childhood, our adolescence, our education, our friendships we've established to date, and so on. So the data are correlational. I can't tell you if social isolation caused the dementia, but also think about it. Dementia causes social isolation. If you can't drive or play cards or think or remember, if you don't have the benefit of a good support system, a loving family, a really good social club, a good living situation, then your opportunities for social engagement dwindle. Okay? So did A cause B? Did B cause A? Did some other factor, C, cause both of those? So we don't know. However, the correlational data are quite compelling, that people who are socially isolated do seem to be at increased risk for dementia, and people who are socially engaged and have vigorous social connections tend to have lower risk for dementia. So even if I can't tell you what the causal link is, I can tell you very confidently, remain socially engaged. Find things that are fun, find good people, go out and get into trouble with everybody, remain socially engaged, because it clearly impacts our brain health. And even if I can't tell you the causal direction, social engagement improves our quality of life. It makes us happy, it gives us a sense of enrichment, purpose, productivity in terms of volunteering, our spiritual life, helping our neighbors, sharing each other's joys and triumphs and sadness about the grandkids and so on, and all that kinds of stuff. So, okay. True to my word, I come back to physical exercise. It is gold. Again, if we're talking only about physiologic function in the brain, not all the richness and complexities of human functioning, physical exercise is what you must choose to preserve and protect the physiological functioning of your brain. This has been studied in a way that allows robust causal statements to be made in terms of very complicated canonical correlational data analyses that are way beyond my head. But we know that physical exercise lowers the risk for cognitive decline and dementia. And for people who do experience cognitive decline and dementia, it almost certainly physical exercise almost certainly results in the later onset of those difficulties, a slower progression of those difficulties, and having greater reserve to deal with and cope with those kinds of difficulties. Something else I came across just while doing some additional research for this talk is that there's a notion now that brain lactate may be one of the reasons that physical exercise is so good for our brain. So vigorous exercise results in the creation of lactate. That gets into the bloodstream, it goes up to the brain, and it crosses what's called the blood-brain barrier. It's this screen the brain has to prevent bad stuff from getting in. Lactate crosses that, and it causes an increase in factors that are associated with neurogenesis, the development of new brain structures and connections, maintaining the richness of it. It increases cerebral blood flow. And remember, the brain's very greedy about its need for oxygen and glucose. And there's clear indications that it results in better attention, learning, and memory. One trick that academicians will often tell their students, for example, before defending a dissertation or before taking a big exam is, go for a swim, go for a run, get on your bike, do something to get the pump going. It's good not just for dealing with the nerves that might come with that, but now we know it also is resulting in physiological processes that are waking the brain up and allowing it to function more effectively. Here's some more good news. Any physical activity is good. Vigorous, frequent, regular exercise is best, but anything is good. Walking when you can, getting in a pool, getting on a stationary bike, it all is good, it all helps. And there's a saying now that sitting is the new smoking. So that's what you want to avoid. Just sitting, not so good. Okay. So let me tell you a little bit about a group called superagers. These are folks who were studied at the University of Chicago. These are folks up to age 109. There was an important exclusion criterion. I added that. They let Bears fans in, I think. See, it was done in Chicago. They probably had a bunch of Bears fans, but I like to think they should have let the Packers fans in. So again, the issue of directionality and causality is confusing with this group, but here are some things that are really encouraging for me. 70% of these folks were smokers. So these are folks who are a very advanced age, 85, 90, 95, 100, 109. Their MRIs of the brains are beautiful. They look like 50-year-olds. Their cognition is remarkable. They do very well on tests of attention, speed and efficiency, learning and memory. But we don't know why they are aging so well. Because again, as I said, some of them are smokers, but almost all quit. Most of them used alcohol. And they all had this playful, wonderful capacity for humor. They didn't take life too seriously. They were curious. They were adventurous. Sleep was good, but not great. I found that interesting. I was sure they were going to say they all slept 9 hours every night religiously. And they didn't. They had routine. They exercised, but they were not berserk about it. But they did all engage in that social connection. They were involved with music, theater, volunteerism. They were mentors. They taught. They took classes. They learned to play the guitar at age 90. So they were really willing to get outside their comfort zone, to reach and to stretch. Okay. So there is hope. There are things we can do to help preserve our brain function and our brain health. And there are medical procedures now and treatments that are available to us sooner when diseases first rear their heads, to get the disease identified and to implement treatments. These treatments now are impacting the pathology, and so it really is encouraging. And I know that's sort of, I don't mean to be Pollyannish, because these diseases are frightening, they're distressing, they cause significant changes in life, and that's unfortunate. But we are light years ahead of where we were 10, 20 years ago in terms of early detection and diagnosis and treatment. And we also have a better understanding now of all the things that any of us can do to preserve our brain function, to enhance our quality of life, and to preserve the most sophisticated, amazing thing in the known universe, the human brain. Two last thoughts, and then again, as I said, I'm happy to stick around for questions. People want to talk, I'll be happy to do that. I've had patients say to me, Jim, if only I knew this when I was 30, 40, about exercise, about not smoking, about all the things I should be doing. And so hindsight can be a cruel taskmaster, or it can be a useful tool. So I don't know about any of you, but I didn't get a crystal ball that said, in this situation, do this. This fad is going to flame out. It's going to prove not to be helpful. In fact, it might be harmful. Is coffee good? Is it bad? Is it good? Is it bad? We don't know. So my concern sometimes when I talk with my patients and when I give talks to these kinds of events is that people might say, oh, I should have, I would have, I could have. And so I want to encourage you to avoid doing that. Definitely, we learn from our past to enhance the future, but we should not beat ourselves up. And in psychotherapy, for example, that's the process often is, okay, well, you can stay mired in your frustration and sadness because you didn't do this. Is that helpful to you? Patients usually will say, no, it really isn't. Okay, it happened. Let's learn from it. So we can't do anything about that. We can do something about today and tomorrow and Saturday. And so let's focus our attention there. And last time I was here, I had some questions afterwards about traumatic brain injury, because it's in the news, it's in all the popular media, newspapers and magazines, and so on. And so I'm going to tell you really quickly that the research does show an increased risk for patients who have been concussed to develop later Alzheimer's disease and Parkinson's disease. In fact, some of the studies show that increased risk is as much as 60%. Exactly. Oh no. However, what you don't read in the newspaper or Newsweek or Time is this. So in one study that was published in the journal Lancet, a British journal, this is what was reported, extracted from that study, and reported on the news, headlines, and so on. This statistic was not reported. 60% increase in Alzheimer's disease if you've had a concussion. That's true. In the study, 5% of non-concussed patients developed Alzheimer's disease. 8% of the concussed patients developed Alzheimer's disease. 5% to 8%. That is, in fact, a 60% increase. But they didn't tell you that 92% of concussed patients didn't develop Alzheimer's disease in the course of that study. That's an important statistic. And if you leave it out, all you do is get people running around frantically saying, oh my God, I don't know about you, I've had 3 concussions. So I'm like, oh my gosh, and my dad had Alzheimer's disease. So I'm not going to go bury my head in the sand. I'm going to do what I can. So we have to be very careful about how we consume statistics that are presented to us, especially in the popular media, because even if the statistics are accurate, they can be misleading, and they can be a source of distress, and so we want to avoid that. You know the old joke about the mathematician and the philosopher and the statistician who are talking about what is 1 plus 1. And the mathematician said, 2. It is axiomatic. It always has, it always will. And the philosopher said, well, what do we mean by 1? And what do we mean by addition? Is it the entirety? Is it a nuanced enhancement? That's a difficult question to answer. And they both looked at the statistician, and the statistician said, 1 plus 1, huh? What would you like it to equal? So, be careful about what you read, please. Okay, and so finally, it truly does take a village. I mentioned earlier that I don't mean to be flippant or Pollyannish at all. These illnesses are serious, they're life-changing, and it truly does take a village to manage them optimally. And so if there are concerns, get information, but please get it from a trusted healthcare professional. Get support, get active, and be proactive. I've had many people come to me who were convinced they had Alzheimer's disease, and we did some testing, and I did a detailed clinical interview, and there were some concerns. And then we said, now, about the 3 hours of sleep and 8 glasses of wine you're having every night, we might want to address that. Okay? So oftentimes there are modifiable lifestyle factors, medical conditions, and also the importance of caring for the caregiver. Because these diseases do affect not just cognition, but the actual person. Things change. And so that takes a toll on family members, especially spouses of patients. And so really important for any of you who have been or are involved with loved ones who have these kinds of diseases to make sure you take care of yourselves as well. And as I mentioned to you at the outset, my family, my mom, Joanne, and my siblings and I found the Wisconsin Alzheimer's Disease Association just to be a wealth of information and a tremendous support and resources. There are lots of organizations out there, lots of ways to get help and information and support. And so, again, if these kinds of healthcare issues are impacting you or loved ones, please try to seek out that kind of information. You can always, my mom knows how to reach me, and if I'm not in trouble and she's not calling me James, she might reach out and pass on my information to you. So if I can ever be of assistance, if you have a question, if you wanted something to read, I am more than happy to be a resource for people. But again, there are wonderful resources here. The neuropsychology department at the Medical College of Wisconsin is phenomenal. So you do have wonderful healthcare resources in your community here. But I'm very passionate about this topic and more than happy to serve as a resource if there's anything I can do to help. And with that, I thank you so much for your invitation to be here and your attention, and I'm happy to address any questions if there are any. Yes, sir.
From your experience, would you say that most primary care physicians have enough savvy about the currency of this to give you good advice, or is it something that you should seek special insight?
Good. So the question is, in my experience, do most primary care physicians have enough savvy? Are they up to speed to really offer good current advice about how to deal with these situations? So first, I practice in Connecticut, not Wisconsin. So I'll tell you my experience is that the extent of the continuum is breathtaking. From people who could give this talk and be much more informative than I just was, to folks who seem to be actively ignoring the issues almost, and everything in between. So I know I don't mean to be evasive, but there is that degree of variability in my experience in healthcare providers. I will also tell you that some folks are so busy seeing 60 patients a day that even if they are savvy and educated and knowledgeable, they're not spending enough time to really get a good handle on that. So I think the important thing is, as patients, we need to be we're willing to assertively advocate for ourselves to make sure that if we have concerns, that we make sure that they are listening and being attentive to us, and if they can't address our question, then not being hesitant at all to go somewhere else or to take it to a specialist such as a neurologist or a neuropsychologist.
Thank you.
Sure.
Where are we at with genetics? I have a mom and an older sister, both have died of complications of dementia. You know, my other sister and I, you know, are of course fearful and monitoring ourselves all the time.
Yeah.
But, you know, how concerned should we be?
So how concerned should we be about genetics, and what role does genetics play in these diseases? genetics clearly plays a role, but it is not determinative. Okay, so if you look at monozygotic twins, so twins who are formed from one fertilized ovum and then that ovum split, so they are genetically identical. If it were all genetics, if one twin got Alzheimer's disease, the other one would 100% of the time. It's not even close to that. Okay, my dad was one of 5. One of his sisters also died of Alzheimer's disease. One sister is deceased. She died at age 98, and 2 of his sisters are cognitively sharp as tacks and in their mid-90s. Okay, they came from the same gene pool. So the short answer, Cheryl, is that genes are important, but they do not tell the whole picture. They do not sentence an individual. A little bit more. The earlier onset in a first-degree biologic relative of the disease, the time at which a diagnosis was made, that tends to imply a greater genetic contribution, but not always. So for early onset Alzheimer's disease, let's say somebody gets diagnosed at age 58 and they have children, that person has children, those children would probably be at greater genetic risk than an individual who gets diagnosed at age 85 and was cognitively intact until 82, and then we saw this gradual decline, and finally a diagnosis was made. And then, as I mentioned earlier, there are now blood tests that can be done that help us identify if there is a particular genetic vulnerability. So there is an ApoE4 gene. All you need to know is there is a gene that can be detected by a simple blood test. It's developed by Athena. And a certain result says genetically you have diminished risk for Alzheimer's disease. If you do not have a good result, then it can imply a higher risk. So I would suggest that, again, if that's something that you're wondering about, it's a simple blood test, and that at least gives you some additional information. Yes, sir?
Yeah, I was just curious. I think everybody can understand that physical activity, and especially as we age, is important for the body, just like it is when we're young. And of course, that would include the brain. But one of the things I always wonder about is that a lot of people who sit aren't just sitting and watching reruns of All in the Family. Or watching football games all day long. They're doing crossword puzzles, jigsaw puzzles. They're reading fiction, nonfiction, newspapers, so they're keeping up with what's happening in the world. And so sometimes I think that, I know when there's a lot of talk now about too much sitting, is new smoking.
Mm-hmm.
But I would think in many cases, that would be more helpful for brain health, because then you're using your brain constantly, more so than I love football, than watching football games all day long.
Yes. So the notion is that if we want to preserve brain health, then doing Sudoku, playing bridge, doing the New York Times crossword puzzle, that those things that are obviously activating the brain should be helpful as well. The empirical research, as intuitive as that sounds, doesn't seem to support that. Now, I'm not saying that don't do them, okay? Because it does help, but the robustness of the empirical findings pales in comparison to physical exercise. Now, some people can't do physical exercise at all, and so they should still be doing those sorts of things. So we haven't found a way to treat the brain like a muscle. If I break my arm, I'm a cast in a sling for 8 weeks, my biceps atrophies, my triceps atrophies, right? And so then I go to physical therapy and they actively confront those muscles to build it back up. We haven't found a way to do that with the brain, to give you cognitive puzzles and exercises and so on to enhance brain function. In brain injury rehabilitation, after people have had strokes or suffered traumatic brain injuries, they will often work with speech therapists. And there's a mistaken notion that what the speech therapist is doing is actively remediating the damage done. And that's not the case. Speech therapy is very important and very helpful, but primarily because they are teaching people about the functional impact of their brain injury, how to accommodate for it, how to compensate for it, how to deal with the frustrations, compensatory strategies, that sort of thing. So, my point again is, keep doing all that stuff, because it probably is helping somewhat. But, if you can exercise as well, please do that. That's the most important thing we can do, based on the current science, to preserve and enhance our brain function and brain health, is to engage in physical exercise. Yes, sir?
What does the literature say about essential tremor progressing to Parkinson's?
So now I am going to be evasive. I'm not sure about the answer to your question. I don't want to give you an incorrect answer. I know, just from my clinical
I didn't hear the question.
Oh, I'm sorry, yes. The question was, say a little bit about the progression of essential tremor to Parkinson's disease. So essential tremor, it tends to run in families. It tends to be limited just to the tremor. It doesn't tend to have the numerous other elements of Parkinson's disease. And so the question is, what's the likelihood that that will continue on into Parkinson's disease? And I think it is uncommon, but again, I want to hasten to add that I'm not certain of that. So I'm sorry I couldn't answer that question more definitively. I don't think it is common. Yes, sir?
Is there a rule of thumb for what constitutes vigorous exercise?
Yeah. Yes, there is. Very simple rule of exercise. Vigorous is when you are breathing hard enough that having a sustained, ongoing conversation would be difficult. Yes, sir.
Do people die of Alzheimer's? Is that?
So the question is, do people die of Alzheimer's disease? Many people with Alzheimer's disease die of some type of opportunistic issue. Pneumonia is very common, for example. However, eventually, Alzheimer's disease starts at the outer ribbon of brain, the cortex. I mentioned, I had a picture up there earlier. That's the computer. That's where it starts. But eventually, over time, it will invade everything, and it will attack the life-sustaining features of the brain deeper in the brain, in the brain stem, and so it will. Yes, if somebody has otherwise good health and so on, then eventually Alzheimer's disease will cause their death. Yes. Any other questions? All right, everybody to the gym, let's go!
Yeah,